Assalamu alaikum. Welcome, students. Welcome to my channel, Orthopedics Made Easy. I am here with very important and interesting topic for you. It's commonly asked as a short note or very short note in your exams. That is metacarpal fracture. So it includes Rolando fracture, Bennett's fracture, and Boxer's fracture. There is lot of confusion between this, which is Rolando, which is Bennett's. So I tried my best to make it clear for you. So please like, subscribe, and share my videos because these are very exam oriented, precise, and simple presentation in the interesting way. So here is the history. There is 20 years old male patient who has pain along the base of the finger. So this is along the base of the second or the third finger or fifth finger. It happened following punch over the wall. So in anger, he punched the wall and suddenly started having pain and the swelling over the wrist region, swelling and along the knuckle and the hand region, sorry, a knuckle or hand region. So this is the mechanism of injury. When someone hits the hard object, the same force come from opposite side and gets caused damage to the bone, that is metacarpal fracture. So we have first Rolando and Bennett's fracture. Rolando and Bennett's fracture is very important and it involves first metacarpal. First metacarpal, that is metacarpal of your thumb metacarpal. So before going to this, we need to know a little about the anatomy of the first metacarpal. So if you see, this is your first metacarpal. So it is having two important muscle attached to it. One is pulling the distal part of the metacarpal towards the ulnar side, that is your adductor pollicis. And one muscle are attached to the base of the metacarpal, that is abductor pollicis longus. So we have two muscles acting here. So one is abductor pollicis longus, which is trying to pull it this way, and this is adductor pollicis, which is trying to pull this way. And we have a very important ligament which is holding the metacarpal to the carpal, that is palmar ligament. So if you see here, we have abductor pollicis longus inserting at the base on the lateral aspect of the first metacarpal, adductor pollicis inserting around the ulnar surface, distal part of the metacarpal. And the third is palmar ligament, which holds metacarpal to the carpal bone. So this is about the anatomy of the first metacarpal. This is again very important thing. So when you try to close the fist, the nails or the tip of the fingers should be directed towards the scaphoid. So that will tell the alignment. So if you see here when you close the fist, the long axis of all the fingers should come and join at the scaphoid. If it is going this way or any finger it is going this way, that indicate that there is some rotational abnormality in the either in the phalanx or in the metacarpal. So what is the mechanism of injury? So when the force is applied to the thumb in flexion, so if there is any force along the thumb, it causes the fracture over the base of the first metacarpal. So what is happening is there is angulation happening due to the adductor muscles pulling this way, they causes angulation. And second thing is the proximal displacement because abductor pollicis will pull the fracture down. So there is shortening or a proximal migration of the fragment, and there is angulation of the fragment at the fracture site due to the pull of the adductor pollicis muscle. So we classify first metacarpal fracture as an extraarticular fracture, partial intraarticular fracture, and complete intraarticular fracture. Extraarticular fractures are very simple. They happen outside the articular surface. So here is your abductor pollicis longus inserted. Here is your adductor pollicis longus inserted. So these fragments tend to move this way. This is extraarticular fracture. Sometimes what happens is only the intraarticular, partial intraarticular, only one intraarticular extension will be there and other is maintained. So here the muscle attaches again abductor pollicis longus. Here is adductor pollicis and here is your palmar ligament. So this palmar ligament holds this fragment in position. This fragment move down, this fragment will go into angulation this way. This is Rolando's fracture. Rolando's fracture is complete intra-articular fracture. We have a separate fragment of the abductor pollicis. We have separate fragment for the palmar ligament. We have separate fragment for the adductor pollicis. So this is three fragment fracture that is extending complete intra-articular. Both intra-articular surfaces has given way. So it's a Rolando fracture. So this is very confusing. Rolando is complete intra-articular, whereas Bennett's is partial intra-articular fracture. It is commonly asked PG bit also, and it's confusing. Sometimes you'll get confused. What is partial intra-articular fracture of the first metacarpal? It is Bennett's. Complete intra-articular fracture is Rolando's fracture. So how will you diagnose it? Here the diagnosis is by X-ray. As a standard X-ray, if you take AP and proper AP and lateral view focusing over the first metacarpal, you will know the fracture line, you will know the displacement. So if you see here, this is the X-ray, here this is the fracture. So it's a completely extra-articular fracture. Extra-articular. Okay. And if you see, this is one fragment here. And this is the another fragment. So it's a partial intra-articular fracture. So this is your palmar ligament. This is your abductor pollicis. This is your abductor pollicis. So this fragment here, it will go this way. Here, it will go this way. This is partial intra-articular. This is again partial intra-articular fracture. So this is all about the extra-articular Barton's, Rolando fracture and Bennett's fracture. So there is, if there is undisplaced fracture, you can apply the plaster and waiter. If it is displaced fracture, you need to go for close reduction as how we did here, or we need to go for open reduction and K-wire fixation. The complication here is malunion because there is a lot of forces acting this way and that way that may causes malalignment. And sometimes no, there is step at the intra-articular surface. Sometimes there is step here, so it will induce arthritis. So malunion resulting in arthritis. So these are the two complications in addition to other general complications of the fracture happening after first metacarpal fracture. Then we'll move on to boxer's fracture. Boxer's fracture is also very commonly asked in your exam, that is minimally comminuted fracture. It's again an extra-articular of fifth metacarpal neck. If you see here, this is your metacarpal. So it happens at metacarpal neck when somebody punches the wall with force. So it's the most common type of metacarpal fracture. This point is also very important. So it's an impaction injury. What is the impaction? Hand is getting impacted over the hard surface. So direct blow with the clenched fist against the solid surface, which causes axial loading, and the neck of the metacarpal gives way. So X-ray, we take it to know the exact level of the fracture, angulation, displacement, and the amount of comminution. So the treatment here is depends on the degree of displacement, either conservative or close reduction and internal fixation with wires. So if you see here, this is your metacarpal. The fracture is happening here. So after the fracture tend to go into flexion. So if we leave like that, it will go into malunion. So the shape of the metacarpal will change from this to this way. So the flexion malunion is very common in this patient. Second thing is, as I told, here is a fracture happening. So this is the long axis. Sometimes what happens, it will rotate this way or it will rotate this way. So that causes rotational malalignment. As I told before, all the long axis should line over the scaphoid. Here, if you see, it is overlying the neighbor finger and not directed. It's directed little medially. So it's either rotational or flexion deformity will get after the boxer's fracture. So this is the boxer's fracture. What we need to do is we need to push this fragment like this. When it gets straightened, we'll pass the wires. So this is close reduction and internal fixation with wires. This is how you treat boxer's fracture. That's all for today's class. Please like, subscribe to my channel.